Thanks for coming. Can everyone hear me with this? Okay. So the purpose of this talk is to focus on antiplatelet therapies for coronary disease. I'm going to really try and focus on the drugs that you'll see in patients in your practices in your clinics. And I have no financial or commercial interest in any of this stuff, so feel free to ask me anything. The primary function of the platelet, as everyone knows, is hemostasis, especially in the high flow arterial system. And this little cartoon is supposed to show the receptors that are important in normal platelet function, but also that are important in disease and that we have drugs for. Essentially what happens is when there's trauma to the blood vessel that exposes the extracellular matrix, there's interaction of the platelet with collagen and von Willebrand factor, and that causes calcium elevations in the cytoplasm, and that causes releases of all the things that everyone's aware of that activate the platelet. There's thromboxane A2 synthesis, ADP release from granules, and thrombin release, and those all promote aggregation. The calcium increases also activate the glycoprotein 2B3A, which causes platelet aggregation. So this is a picture of an artery from a patient that had an ST elevation of I and obviously didn't make it. But it shows the components of the coronary disease and the thrombosis. The ST elevation of I results from rupture of this cholesterol-filled plaque, and inflammation shear forces disrupt the fibrous cap and causes exposure of the underlying components, which are which cause platelet activation, and that results in what was not an occlusive stenosis becoming suddenly occlusive, causing your ST elevation of I, and that thrombus is very platelet rich. Get another cartoon of the platelet just showing the receptors, and we have drugs against all of these receptors. The one that everyone's most familiar with is aspirin, which irreversibly inhibits thromboxane cyclooxygenase and prevents production of thromboxane A2. But we also have drugs that inhibit the PAR1 receptor, which is a thrombin receptor. And we have a number of drugs that inhibit the P2Y12 receptor, one of the ADP receptors. Again, drugs that you're probably very familiar with, ticlopidine and Clopidogrel, and newer ones, Prasugrel, ticagrelor, and cangrelor. And then we have very potent intravenous drugs that inhibit the glycoprotein 2B3A receptor. I'm going to mostly focus on the ones that come oral that you'll see in your clinic patients. So again, the purpose of this talk is to look at the risk and benefit of all these antiplatelet therapies that are commonly seen in subgroups of patients. And I'm going to focus on both their benefits and their risks, because again, it's always a trade-off with these patients. You're trading off prevention of thrombosis to prevent arterial occlusion versus the bleeding risk. So again, this is a drug that everyone's very familiar with. Aspirin is the oldest and most commonly used antiplatelet therapy. It irreversibly inactivates cyclooxygenase, preventing production of thromboxane A2. This has been around for a long time. It's old, cheap, weak antiplatelet effect, usually well tolerated, and again, the one that's most commonly used. This is the slide from the ISIS-2 trial, which is an older trial of aspirin and thrombolytic therapy in patients with acute MI. And this is really the first trial that really showed how effective aspirin is for acute MI. Large trial, over 17,000 patients, and they were randomized to one of 4 groups. There was a placebo group. They got placebo infusions of streptokinase, and they got placebo tablets. There was a group that got just aspirin, a group that got streptokinase thrombolytic therapy, and a group that got streptokinase and aspirin. And you could see that streptokinase and aspirin had a dramatic improvement in outcome. The outcome here is vascular deaths. And reduced the rate of vascular deaths from 13.2% to 8%, so a dramatic effect. You can see just aspirin alone reduces it from 13.2% to 10 to about 11%. Really, that aspirin, that little cheap aspirin, is as good as your expensive thrombolytic therapy. But the effects are additive, so we use both of them. So aspirin, it's a no-brainer in someone with acute MI, acute stroke, very dramatic benefits in that group of patients. So that's a group that's easy. In the years since this trial, which is from the late 80s, there hasn't been that much improvement in thrombolytic therapy. You know, there's the Gusto trial, which showed TPA was better, and we used the newer agents that are easier to give. But there really hasn't been much change, whereas the antiplatelet drugs, you'll see we've made dramatic improvements. So again, acute MI, acute stroke, acute ischemic stroke, very dramatic benefit of aspirin. So those are no-brainers. This is a meta-analysis of trials available before 1990. So again, old trial, old study, looking at the benefit of aspirin in various patients. And again, the groups that are sort of no-brainers, so this is 9 trials in patients with acute MI. Again, this side is antiplatelet therapy is better, antiplatelet therapy worsens the outcome. You can see for things like acute MI, very high-risk patients, the benefits are very dramatic. In secondary prevention, people who had an MI like a year ago or a stroke, an ischemic stroke a year ago, there's also very dramatic benefit. The group that's harder, and we'll look at that more closely, is the primary prevention group, where you guys probably see most of your patients who haven't had an MI or ischemic stroke. And there you can see there's a suggestion of some benefit, but it really isn't all that statistically significant. It crosses the equivalence line. So that's a much harder group. This slide's from a secondary prevention trial, and this is a meta-analysis of 6 trials of using low-dose aspirin, less than 325 milligrams, 6,300 patients if you add up all the trials together. And again, a dramatic benefit to aspirin that you decrease death, and that's highly significant. You decrease vascular events, you decrease myocardial infarction, you decrease stroke, all of those by about 30%. But the other problem with it, if you look at this one, GI tract bleeding, you get a 2.5-fold increase of GI bleeding by aspirin. So there's a trade-off there. You decrease ischemic events, but you increase bleeding, especially GI bleeding. This slide is looking at the overall effect and number needed to treat. And you can see the number, and again, this is for secondary prevention, people with a history of MI or ischemic stroke in the past. The number needed to treat to prevent 1 death is 67. The number needed to harm to cause 1 GI bleed is 100. So it's clearly in favor. And then the other thing is that none of these GI bleeds were fatal, and most of them weren't even bad enough to require you to stop the aspirin. So again, for secondary prevention, aspirin's pretty much a no-brainer in someone without contraindications. Again, primary prevention, people with no history of MI or stroke is much, much harder. This is one of the large primary prevention trials in women. This is from the Women's Health Study, which looked at about 40,000 healthy women, or at least they were healthy when they started this study, who were more than 45 years old, and they were randomized to getting 100 milligrams of aspirin every other day. If you look at the primary endpoint, which was first major cardiovascular event, CV death, MI, or CVA, there really was no statistically significant benefit. But at least in women, unlike, which is the opposite of men, if you look at stroke, there is a benefit to aspirin. This is all strokes, this is just ischemic stroke. But in women, unlike men, if you look at MI, there's really no difference. The lines are really on top of each other. And aspirin had a downside. There was slightly more hemorrhagic stroke. So again, it wasn't statistically significant, but there was a significant increase in GI bleeding. So again, if you look at aspirin for primary prevention in otherwise healthy people, you get this balance between preventing ischemic events, which is very small, and this increase in GI bleeding, which isn't as bad as ischemic events in many ways, but it sometimes can be a wash. And so these are the recommendations from the Preventive Services Task Force. And I'm sorry, this is a hard slide to read. It's just this top part which you really need to look at. But the reason it's a complicated slide is because the calculations are complicated. They basically recommend aspirin for primary prevention in men 45 to 79 who don't have any GI problems or GI bleeding and who are high risk. So they have all these calculators. You can download the apps to your phone. You can go to these websites, which they list here, and look at it. But it's not as simple as saying all men over 45 should be on aspirin. It should really be limited to people who are high risk for vascular disease and who are low risk for bleeding. And women, the age goes up to 55 to 79. And again, it should be women who have other risk factors and not giving it to all women who are over 45. And really the most important thing is probably having a conversation with many of these patients, how much they're want to prevent MI and stroke and how much they're concerned about the GI and tell them the risks and benefits. But again, not as simple as your secondary prevention patients who already have vascular disease, where the benefits clearly outweigh the risks. The next thing I was hoping to talk about is the dose of aspirin, which remains controversial, whether people should get 81 milligrams, whether they should get 162, or whether they should get 325. There aren't a lot of randomized studies, and the studies that are out there are small. This is from the CURE study, which is really was a randomized study of adding Clopidogrel, which we'll talk about later, to aspirin, or just aspirin alone. The study didn't specify the dose of aspirin, so different institutions gave different doses. Some gave 75 or 81, some of them gave essentially 162, and some gave the 325. And so this is a post hoc analysis of looking at the different doses. They defined as less than 100, more than 200, which is usually the 325 dose, or an intermediate dose. And then, this is looking at the benefits of aspirin. Again, the gray ones are aspirin alone. The black ones are aspirin and Clopidogrel. And you can see there's no difference. There's no advantage to going to higher doses. If anything, as you go to higher doses of aspirin, you have worse outcomes, more ischemic events. And that's true whether you are on just aspirin alone or on Plavix. Again, it doesn't meet statistical significance, but essentially there's no difference in the different doses of aspirin. 81 works just as well as the 325 for preventing ischemic events. This study looks at incidence of major bleeding. And you can see as you go up on the dose of aspirin, you get more bleeding, primarily GI bleeding. And that's true whether you're on just aspirin alone, the gray ones, or whether you're on aspirin and Plavix. So basically, when you go from 81 to 162 to 325 milligrams of aspirin, there didn't appear to be any benefit as preventing stroke, MI, death, but you just got more GI bleeding. And again, not a definitive study because it wasn't randomized with the aspirin, but this and other studies suggest that you should go with lower doses of aspirin. The next topic that I was hoping to talk about is aspirin resistance, which has been in the literature quite a lot. Let's talk about some patients who seem to be aspirin non-responders and what to do with them. This is a study that was trying to look at the mechanism of aspirin response. And I think they were a little bit surprised at their results. Basically, they took healthy people and they gave them different doses of aspirin and measured aspirin response by drawing their blood and looking at platelet aggregometry. They looked at metabolites of thromboxane E2, and they were surprised to find a difference as to whether they got soluble aspirin, non-enteric-coated aspirin versus enteric-coated aspirin. In fact, in people who were getting soluble aspirin, they couldn't find any cases by any of their different criteria of aspirin resistance. All the aspirin resistance was in the people who got enteric-coated. And here you can see, if you measured it 4 hours after getting the enteric-coated aspirin, there was almost a 50% rate of being an aspirin non-responder by these biochemical measurements. And even if you went to 8 hours, there was a 17% rate. So it didn't appear there was this true mechanism, there was this true aspirin resistance. It was all pseudo-resistance. It was people not absorbing the enteric-coated aspirin. So again, not definitive, but I think the message there is tell your patients not to take enteric-coated aspirin. At least most of the patients who come to my clinic are on enteric-coated aspirin. And this is a significant concern. If you go to Walgreens, it's really hard to find just plain aspirin. You end up having to get the chewable, and all the companies make it. So again, not definitive, but there's no evidence that enteric coating prevents GI upset. There's no evidence that prevents ulcers. Encourage all your patients to use chewable or non-coated 81 milligram aspirin. The next group of drugs that I was hoping to talk about that you guys all see in your practices are the Adp receptor antagonists, or the P2Y12 inhibitors. There are 4 of these that are available in oral form, and you probably see in your clinic all the time. Cangrelor is the most recently released, and that's an intravenous form, so I don't think you'll be seeing your patients on it in clinic. The first one that was approved that's been around for quite some time is Clopidogrel or Tyclid. And the interventional cardiologists have been using these drugs since the late 90s for coronary stents. Before that, Clopidogrel was mostly used to prevent ischemic stroke. But when stents first came out in the early 90s, we had a lot of people, you'd get a great result. The angiographic result would look beautiful, but when they were discharged from the hospital in the parking lot, they'd suddenly come back in with MIs because of acute thrombotic closure. And these stents were first put in Europe, and they basically threw the book at it. Every drug we had, they tried to put them on to look for something that would prevent these stents from suddenly closing. And what was mostly settled on was warfarin, which caused a lot of problems. And once we found these new antiplatelet agents, these Adp receptor antagonists, we had a great improvement. This is the first study that really showed the benefit of Clopidogrel for preventing stent closure. They randomized about 1,500 patients to either aspirin alone, aspirin and warfarin, or aspirin and Clopidogrel. And you could see warfarin, which was the drug that we had been using all that time, really didn't decrease stent closure very much. This is death, thrombosis, and revascularization improved from 3.6% to 2.7%, not much benefit, but you had this huge increase in vascular bleeding. So warfarin, you sort of got the worst of both worlds. It really didn't prevent stent closure, but it greatly increased all your bleeding complications. And when they found this drug, Clopidogrel, you had this 7-fold decrease in the rate of stent thrombosis, but there was a price to be paid for that, and it was bleeding again. What we see with all these antiplatelet drugs. Really, despite our impression that there's much less bleeding with these drugs than warfarin, none of the studies have really shown that. The hemorrhagic complications a little bit better than warfarin, but really not much. But at least with Clopidogrel, you had this dramatic 7-fold decrease in the rate of stent thrombosis. But for those of you who have used Clopidogrel, you're probably familiar with all the problems with it. It's not a well-tolerated drug. In addition to bleeding, which is a big problem, there's a very high incidence of people getting rashes. You have to follow CBCs in these patients because there was a significant incidence of neutropenia. At least my clinical impression was higher than this. It wasn't that uncommon that we'd have to stop it. And it had this incidence of TTP, which is very devastating. But fortunately, in the late 90s, we had a new drug that came out, which is Clopidogrel or Plavix, which is another thienopyridine, very similar in structure to Clopidogrel. It has the only difference is this one side branch is different. But with that difference, it was much better tolerated, much better GI tolerated, much lower incidence of rashes. You didn't have to follow CBCs so closely. They didn't seem to get the neutropenia and the TTP. And in stent trials, it was at least as beneficial as Clopidogrel. It seemed like you could just trade out one for the other. It prevented stent thrombosis as well. If anything, it was better, probably because you didn't have patients stopping it because of all the horrible side effects. This is one of the first big trials with Plavix, with Clopidogrel, using it long-term for patients with coronary disease. This took patients who had, again, this is in the era of bare metal stents. They had bare metal stents. Instead of just for treating them for a month, they treated them for a year with Clopidogrel. It's Clopidogrel plus aspirin versus just aspirin alone, which is the placebo one. And you could see that if you extended out the period of Clopidogrel going from just treating them for a month after the stent to a whole year, you had this marked improvement in the incidence of vascular death, MI, and stroke. And it increases the whole time. So the whole year you got a benefit from keeping patients who had acute coronary syndrome and got a stent on these drugs. So instead of just using the Clopidogrel for 1 month, we were began to use it up to a year. And again, this just shows the same numbers. There's a 27% decrease in the risk of death, MI, and stroke. Stroke was only 10%, but MI is about 25%. And the mechanism wasn't preventing stent thrombosis late, because that really wasn't very much different. This is target vessel revascularization or urgent target vessel revascularization, usually from stent thrombosis. There was a small effect, but the effect was in preventing strokes and events in other parts of the coronary tree and the cerebrovascular area. The next trials looked at the dosing of clopidogrel. I don't know how many of you guys are in urgent care, but nowadays we load them with Plavix, and this is one of the first studies to show the benefit of that. This study looked at whether preloading with clopidogrel before your stent procedure or just when they come in has an advantage. These are actually patients who received thrombolytic therapy for ST elevation MIs, and they were randomized to getting 300 milligrams of Plavix right away, or waiting till they had a stent put in. And you can see this is after getting thrombolytic therapy, but before getting their stent procedure. And the top line is no pretreatment with Plavix with clopidogrel. The bottom line is getting pretreatment. And again, pretreatment prevented these vessels that had been opened up from thrombolytic therapy from reclosing before you did your cath. And you had a significant improvement with Plavix. And then once you did your stent procedure, that benefit remained. And all these were statistically significant. So Plavix, clopidogrel pretreatment with 300 milligrams significantly improved both the short-term outcomes before the stenting and improved the long-term outcomes out to 30 days afterwards. And there have been further studies which define the dose of the clopidogrel, which you should be giving, if these patients show up with an MI in your clinic or in urgent care. This is from the Armida study, small study, but this randomized people to getting 300 milligrams of clopidogrel versus 600 milligrams. And you can see there's a dramatic threefold improvement in the rate of recurrent MI if you gave the higher dose of clopidogrel. The problem with clopidogrel, it's a prodrug. The drug, clopidogrel itself isn't active. It has to be metabolized in the liver, and it takes a while to work. And you really have to give this high dose to start getting a benefit right away. And so we're going to bring up one other issue with clopidogrel, which I think comes up in your practices all the time, is drug interactions. There's a black box warning, if you look in the package insert with clopidogrel, warning you not to use proton pump inhibitors because it blocks the liver enzymes that convert clopidogrel to its active drug. But clinically, that doesn't seem to be the case. There was actually a company that was called Cogentis, which actually developed a drug that was a combination of omeprazole and clopidogrel. And they sponsored a randomized study where patients who were getting stents were randomized to get their drug, this combination drug, versus just clopidogrel alone. And if you look at this first slide, it shows the GI endpoint, GI bleeding. And adding omeprazole to the clopidogrel greatly decreased the incidence of GI bleeds, but it had absolutely no effect on ischemic events. So there's this great fear when your patients go to the pharmacy and the pharmacist gives them both, they warn them not to take one of them. And so they end up not taking their Plavix, or end up not taking their omeprazole. But clinically, this doesn't seem to be important for causing ischemic events. So when you see them in clinic, I don't hesitate to give them omeprazole, at least at this 20 milligram dose. I mean, I think I still worry that at the higher doses, maybe there is some true effect, but at least at 20 milligrams, that omeprazole just prevents GI bleeds and doesn't seem to increase the risk of ischemic events. The next P2Y12 inhibitor that was approved by the FDA is Prasugrel. And this tried to get over some of the problems with the problem of loading with the clopidogrel. This is a much more potent drug than clopidogrel, and it works a little bit faster. So this is a study in healthy subjects, just loading them with Prasugrel and continuing a dose, or loading them with 600 milligrams of clopidogrel and continuing a maintenance dose, or 300 milligrams. And this first one is the way that we traditionally did it, giving 300 milligrams of clopidogrel followed by 75 milligrams a day. And this measures platelet inhibition. You can see if you go to the 600 milligram dose, you get more rapid and more potent platelet inhibition. But if you change to Prasugrel, you get very, very rapid platelet inhibition and much more effective than the clopidogrel at inhibiting platelets. And so this was studied in patients with acute coronary syndromes, very large study. This is the Triton-TIMI 38 trial. And that basically randomized patients with acute coronary syndromes, very large trial, over 13,000 patients. They were randomized after they had their heart cath, but before their angioplasty procedure. And you can see if you compare clopidogrel to Prasugrel, you get a reasonably impressive decrease in the primary endpoint, which again is death, MI, or non-fatal stroke, from 12% to about 10%. And that's highly significant. So it definitely was beneficial, but the problem was bleeding. You got this improvement in this as far as ischemic events, but certain patients, they realized had a very high incidence of problems. And the biggest group that had problems with patients with a previous history of TIA or stroke, a high incidence of intracranial bleeding, which is obviously devastating, but also patients over 75 had more problems with bleeding than they did benefit. And petite people, especially women under 60 kilograms, didn't do well with the drug. So this is a complicated drug. It's much more potent platelet inhibitor, but then you pay this price with high incidence of bleeding. So if you look at the warning for the drug, it's advised not to give it in people over 75, not to give it in anyone with a history of TIA or CVA, and not to give it in people who are less than 60 kilograms. So that's always a hard thing. You know, when someone's in the emergency room having an acute MI and they're in a lot of pain, it's often hard to get a history. So you're asking your ER physician to figure out all this stuff and quickly decide. It's made us very hesitant to use Prasugrel, but it probably does have some benefits in someone who's very low risk for bleeding and high risk for thrombosis. Again, this is that same slide. If you look at the overall trial, the number that you need to treat for benefit from going from Prasugrel to clopidogrel was only 46, so it looks pretty good. And the number needed to harm was 167. So if you look at all comers, it probably is a beneficial drug. It's just sorting out which patients will benefit and which patients will have a very high risk of bleeding that makes this one complicated. Ticagrelor is the newest oral ADP receptor antagonist that we have. I don't know how much you guys are seeing it. I'm starting to see it in a lot of patients. It was approved by the FDA in July 2011. The advantage of this drug over the previous ones, it has a very rapid onset of action. It's a very potent antiplatelet inhibitor. It's active. There's none of these issues of metabolism. The drug itself is the active drug, so you don't have to worry about all these drug interactions and things preventing it from being effective. It has a short half-life, so if you stop it, it goes away quicker, but the disadvantage with that, it's now BID dosing. So if compliance is an issue with your patient, it's not as convenient for them, and it's expensive. And this is from the Plato trial, which came out in 2009 and really led to FDA approval of it. This randomized over 18,000 patients with acute coronary syndromes to getting our traditional drug, clopidogrel, or ticagrelor. And you can see that ticagrelor, again, a more potent antiplatelet inhibitor. When you look at the overall thing, it's not so obvious, but when they magnify it up, you can see the patients on ticagrelor did better. It decreased the rate of death, MI, and stroke from 9.8%, to 9.8% from 11.7%. Total deaths were reduced from 5.9% to 4.5%. But the problem with this drug also was bleeding. There was no increase in overall bleeding, but there was an increase in the most severe type of bleeding, which is intracranial hemorrhage. And the other problem, actually, if you just look at the primary endpoint, marked improvement. If you look at major bleeding, there was some increase of that, so that always makes us a little bit hesitant in high-risk patients. The thing about this study that delayed it getting approved by the FDA is that in North America, which didn't recruit that many of the patients, out of maybe 10% of the patients didn't do so well with ticagrelor, much different than the European centers. And it wasn't clear why that is, but it's thought to be due to that. At that time in North America, we were using 325 milligrams of aspirin, whereas in Europe at that time, they were using 75 or 81 milligrams of aspirin. So the current recommendation is if you're going to use ticagrelor in your patients, or any of your patients on ticagrelor, they should never be on more than 81 milligrams of aspirin. And probably none of our patients, at least the coronary disease patients, should be anyway. But very important not to use 325 milligrams, because any benefit from ticagrelor is more than diminished by the risk of bleeding. Again, ticagrelor has also been studied for secondary prevention, add-on to aspirin. This is from the Pegasus trial, which is a secondary prevention trial. 21,000 patients who had an MI in 1 to 3 years previously were randomized to get placebo or 2 different doses of ticagrelor. And again, the results are the outcomes are so good now, you really have to have a big study to show improvement. But the endpoint, which again is the cardiovascular death, MI, and stroke, was reduced from about 9% to a little under 8% with either dose of the ticagrelor, which was in this big trial highly significant. But again, there was this price to be paid, just like all the other antiplatelet drugs. There was a significant increase in major bleeding. Again, these are relatively low-risk patients, and it wasn't dramatic, but from 1% to over 2%. So again, a price to be paid. And I was just going to mention this drug quickly. This is a drug that we use in the hospital, not in your clinic. This is Cangrelor, which is the newest ADP receptor antagonist to be approved by the FDA. And this is an IV form. It's very fast acting, so as soon as you give the bolus, it has an effect. And the reason it was developed, many of our patients who come in with MIs and acute coronary syndromes, they're coming in, they're sick, they're having nausea and vomiting, they've just had an arrest, they can't swallow. So the advantage with this drug is you can give it intravenously. Because even with the fast-acting ticagrelor, you still have to somehow get it down. And many of these patients can't do this. So this is an IV form, just available, that can be given in the hospital in patients with acute MI or acute coronary syndromes. This was a study compared to just bolusing clopidogrel orally and giving this drug. And again, clopidogrel is probably not the right one to compare it to nowadays. It's probably ticagrelor, because clopidogrel, as we talked about, acts slowly. But in these patients who have acute coronary syndromes and need to get it quickly, you can see, and this is just a 48-hour study, Cangrelor decreases the risk of the stent closing down again. So decreases death or MI or emergent revascularization quite substantially in these patients. It's not clear if they had preloaded these patients earlier with clopidogrel or if it was ticagrelor, if you'd get such a dramatic benefit. The next controversy that I was hoping to talk about quickly, which comes up in your clinic patients, is how long to keep these patients on clopidogrel or the other adenosine receptor antagonists after they get their stent. This always comes up because they need surgery afterwards, or things come up and the surgeon wants to stop it, or they're having bleeding problems. And there have been a number of studies that tried to look at this with variable results. This is the biggest of those studies. It's called the DAP, or the dual antiplatelet therapy trial. And this enrolled about 10,000 patients who had gotten drug-eluting stents to the usual 12 months of dual antiplatelet therapy, or extending it out to 30 months. And you can see there is a benefit to extending the drugs out. Stent thrombosis was reduced from 1.4% to 0.4%. MIs were cut in half. But again, there was a price to be paid. The rate of bleeding increased from 1.6% to 2.5%. And the most important one, which worries everyone, is death. I mean, it's pretty easy to count that one. And this was statistically significant. So you did have a benefit as far as preventing stent thrombosis by extending out the duration of your antiplatelet therapy. But the price you paid was more bleeding, and this is statistically significant. P was 0.03, so you had more deaths in that group. So that's worried people. And the bottom line with this study is whenever you stop these drugs, in the first 3 months, there's this incidence of events. And it's not only stent thrombosis, it's events in other places in the coronary tree and the cerebrovascular tree. So whenever you stop it, in those first 3 months, you're going to get that increased incidence. And even these people who went 30 months, once you stop in those first 3 months, things happen. There have been a bunch of studies looking at even going shorter periods of time in these patients. This is a study that looked at a stent, the Zataralemma stents, which isn't the one that we mostly use, of going 3 months versus the 12 months. And again, these aren't acute coronary syndrome patients. These are patients who had elective stenting for angina. And they basically were randomized to stopping the adenosine receptor antagonist at 3 months versus 12 months. And probably this is the line to look at. This first part, I don't know why there was a difference between the two groups. That's just random chance that both groups are on the Clopidogrel or whichever ATP receptor antagonist. But the lines are almost on top of each other. There still looks like there's some benefit to keeping the ATP receptor longer as far as preventing events. Again, short term is here. This is the long term, but it's very small and not statistically significant. So, at least with the effort, with this stent, there didn't seem to be a big advantage for going longer than 3 months. So it may be that the guidelines will change. And I think the results, at least from most of the studies, are even better with the Zion stent, which is what's most commonly used here and elsewhere. So if you need to stop the person's having surgery, something else is, or they're having bleeding, if you need to stop after 3 months, it's probably safe. I was hoping to talk about one more drug, and I don't know how much you guys are seeing this. The one receptor on the platelet that I showed at the beginning, which I haven't talked about, is the thrombin receptor, the PAR1 receptor. And there's a number of drugs under development. This is the one that's FDA approved called Varpaxar, which is a potent thrombin receptor antagonist. It was FDA approved in May 2014 based on a couple different studies. This is from a large randomized study that was published in 2012. It randomized about 13,000 patients with acute coronary syndromes, but not ST elevation MIs, to getting this thrombin inhibitor on top of usual therapies. That usually was aspirin and clopidogrel, whatever ADP receptor they were using. Boy, it's almost hard to see the lines separating. But this is events on the y-axis. Again, MI, non-fatal, or I mean death, non-fatal MI, or non-fatal stroke. And you can see there's a small benefit from the thrombin inhibitor versus placebo. But the lines that really separate out are the bleeding. So you got this small benefit from this thrombin inhibitor. And again, these are serious bleeding events in these two, but a large problem with bleeding. And actually, this bleeding, the one that was really increased is intracranial hemorrhage, especially in people with a history of CVA or TIA. So this drug really should not be used in patients with previous cerebrovascular events. And this is a similar trial, but instead of being in acute coronary syndromes, this is for secondary prevention, people who had an MI or 3 years previously, or 1 to 3 years previously, or who have peripheral arterial disease. Again, with this thrombin inhibitor, you see a small improvement in the endpoint, which was, again, death, MI, or CVA, but a big increase in severe bleeding. And so I think we were a little bit surprised to see that this drug was that Merck was able to get this through the FDA. But I guess if you use it in the right patients who are very low risk of bleeding and have a lot of peripheral arterial disease, very high risk for ischemic events, you can show some benefit. But this is a drug that we've been very hesitant to use because its bleeding profile is bad, even though it is efficacious. Just quickly in conclusion, the big message I want to get that all these antiplatelet agents are a trade-off between preventing vascular events, preventing ischemia, and preventing them from having good functioning, in other words, causing bleeding, as well as the other side effects. But you always have to weigh those risks and benefits in all of these patients. Aspirin is clearly beneficial in patients with acute coronary syndromes, MIs, and it's clearly beneficial for secondary prevention, people who have had MIs or ischemic strokes or have peripheral arterial disease. For primary prevention, the math is much more difficult. It is recommended for males over 45, females over 55, if they have if they are high risk for vascular events, and if they're low risk for bleeding. I think you really have to talk it over with those patients. For most patients, at least the coronary patients, use low dose aspirin, use the 81 milligram, and try and avoid enteric coating because there are issues with absorption. The ADP receptor antagonist, probably most of what you see is clopidogrel, should be used for 1 year in patients who have had acute coronary syndromes or have coronary stents. I think for the non-acute coronary syndrome, for your stable angina patients who get stents, I think in the next couple of years, you're going to see the recommendations change and will allow for a shorter duration of using these drugs, which will make it much easier for your patients who are going to need surgical procedures or who have bleeding problems. I'm going to leave a lot of time for questions. Yeah, go ahead.
In the city where I practice, the cardiologists have been studying people on aspirin and Plavix for the rest of their life. And I have a lady who's 80 years old who's been on Plavix and aspirin for at least the last 10 years. And recently she's been getting nosebleed, and I told her to stop the Plavix. Cardiologist just agreed with me, told her to stop the aspirin to continue.
Yeah, do you remember what kind of stent the patient had?
Drug-eluting.
Yeah, do you remember if it was a Taxus or how long ago did they have the drug-eluting stent? In other words, how many years?
10 years ago.
10 years ago, yes. That was the previous generation of stents, and I didn't show that. When you looked at if you go back to the original study, see if I can find that. Let's see which one randomized the time. If you looked at the DAP trial, there was a difference depending on the type of stent. And again, this is all subgroup analysis, and the statistical analysis is controversial. But I think there's a big difference between the older stents, especially the paclitaxel stents, and also the Cypher, the sirolimus stents. The first generation are clearly a problem. We don't use them anymore. They're not out there anymore, but you still have patients who are on them. But those clearly had those were the ones that really closed. The second generation drug-eluting stents, what we use now, mostly everolimus, is much better. So the paclitaxel stents are a little bit more of a problem, and maybe the location has the cardiologist worried. But even in those patients, when you start getting beyond a year, the risks of bleeding, especially intracranial hemorrhage and serious bleeding, start to outweigh the benefit. So once they've been beyond a year, it gets very controversial to keep it going unless there's something very unusual about the patient. They're very high risk. It was put in their left main, and they're very low bleeding risk, and maybe those it's worth it if they keep having events. But for most patients, once you start going on beyond 12 months, the bleeding risks start outweighing the benefit from ischemic protection. And again, in this DAP trial, there was statistically significant increase in the rate of death. That's a pretty bad endpoint. Yeah.
Has anyone looked at doing step-down antiplatelet therapy at that 12-month mark?
Yeah, weaning them off of it then. Well, you sort of do wean them off because when you stop these drugs, they're very long-acting, so they get out of their system slowly, and you don't stop the aspirin. That's something else I should have mentioned. All these trials, they leave the aspirin on board. And you probably do not, especially in people with the paclitaxel stents, do not want to stop both aspirin and the ADP receptor antagonist at the same time. You can all avoid it. Sometimes you're stuck. The person ruptured their aneurysm, or they're having a massive GI bleed. But I think the really dangerous thing is stopping both clopidogrel, for example, and aspirin at the same time, and anything you can do to avoid that. So the surgeons will often operate on people, again, assuming it's not a neurosurgical procedure, on people on 81 milligrams of aspirin a day. When you add the aspirin and the clopidogrel together, the bleeding is so bad, but usually if you can just stop one of them, it's much preferable.
But nobody's looking at stepping
like giving them half of the clopidogrel or half of the ticagrelor. No, I don't think the pharmacokinetics would justify it because it gets out of your system so slowly. They have such a long half-life, over 7 days, which is the problem when someone uses urgent bleeding. Yeah, go ahead.
Hi. I was wondering what recommendations you make for using NSAIDs in this scenario.
Well, we always prefer none, which is easiest per se. We're not the one in pain. But, all the data with non-steroidals for any of our vascular patients increases the risk of vascular events, the COX-2 inhibitors seem to be worse. It seems to be a spectrum, but all of those are bad in our vascular patients, and they obviously increase the risk of GI bleeding. So the cardiologist would prefer none. Of course, we're not the ones in pain. So, I think it's weighing the risks and benefits, but clearly we prefer not, if they're not on it. Yeah, go ahead.
Two good questions.
Yeah.
When do you decide to use a bare metal stent, and why is it that the DAPT is not necessary for more than a month for bare metal?
Yeah,
as compared to the
I was going to.
And the second question is, are there different age groups which are more prone to major bleeding risk? How do you choose the patients? Would you give Cangrelor to a 75 plus or 80 plus patient?
Yeah, those are both good questions. So I was going to show that, but I sort of took it out to save time. So the bare metal stents get endothelialized very quickly. And so, there was a study which I used to always show that you can get away with 2 weeks of, it was done with Ticlid because, you had so many side effects with that, the ticlopidine. But you can get away with 2 weeks of dual antiplatelet therapy with those. Whereas the drug-eluting stents, you have this nice drug that prevents that rehealing, that prevents overhealing and the scar tissue formation, but it also delays endothelialization. When they were developing these, they really showed that in animal models and in humans. So that's why you need the extended therapy in those people, because you still have this polymer, and this metal stent that's exposed for a much longer time. And that takes about 3 months. So you really need those for 3 months. So say we don't use many bare metal stents anymore. Let's say someone has a colon cancer and they have horrific angina, and so they're sent to you because they're having angina with just walking 2 feet or all the time, yet they need to get their hemicolectomy. That's a patient that you might want to use a bare metal stent. You can put the bare metal stent in, leave them on their Plavix for 2 weeks, stop it, and a week later or 5 days later get their surgery, and just leave them on 81 milligrams of aspirin. Or if you put in a drug-eluting stent, you're worrying more that you have to go 3 months. And then your second question about who to use.
Age stratification for use of
Yeah, clearly as you get older, you saw, for example, where you see it most is in the very potent drugs like the Clopidogrel, where over 75, it's considered a contraindication, or you drop the dose in half. But clearly as you get older, your bleeding risk goes up. And so the risk benefit gets complicated. On the other hand, that patient over 75 is also higher risk for vascular events. But for the very potent ones, you really should avoid Clopidogrel in people. That's a good drug for your 55-year-old. There's no bleeding risk and has a lot of coronary thrombosis. But as you get older, you need to be more careful. On the other hand, they're higher risk for thrombosis as well. And Cangrelor, I don't know. We don't use it here yet. We tend to give Ticagrelor, have them, the ERs will crush it up and give it as a liquid, and it gets on board really quickly. So assuming they're not having nausea and vomiting, that works well. The Cangrelor, though, really didn't have a higher risk of bleeding. The advantage with that, it's very short acting. If you get a problem, you shut it off, it's gone, and you're only using it for 2 hours. But again, all these very potent drugs are probably, should be avoided in the older patients.
We have time for one more.
Yeah, go ahead.
I have a patient who had an NSTEMI. He's in his 70s and is on Plavix, and he does not want to continue Plavix because he had previous intracranial hemorrhage and is afraid of the bleeding risk. I've talked him into staying on it, but with the new data on the non-MI patients, you can cut off at 3 months. In this patient, what do you think?
Yeah, so did he have a stent placed?
Yes, he had a stent.
Now that 3 month versus 12-month trial, that's in patients who had stable angina. That's not in your acute, not an MI patient. But I think it's always, and he did have a stent placed?
Yeah, he had a stent placed. And he is at high risk because he had an NSTEMI, but at the same time, he is at high risk.
Yeah, so it's always weighing the risks and benefits in these patients. And I think if he was really worried about it, as long as he stayed on his non-coated aspirin, you can try it, but it's a discussion of the risks and benefits. And I presume he had like the newest science, everolimus stent probably. I think, if you get 3 months, those patients generally do very well. But again, those studies showing it's safe to go 3 months are mostly done in non-ACS and non-MI patients.
Thank you, Dr. Singer.
Yeah, thank you.
We have a little break scheduled till 10 o'clock, and prevents